Greetings everyone, and welcome to another edition of Cosmetic Corner. My name is Chris Surek, your moderator, and I'm very excited today to bring with you an interview that I had with Dr. Val Lambros. Unfortunately, Dr. Lambros was unable to video Skype with us. However, he did leave me with some very thoughtful insights on a recent article in ASJ. The article we discussed was by Dr. Claudio DeLorenzi. It was a special topic article looking at hyaluronidase treatment for intravascular filler injection. In this article, he discusses a new novel approach to management of vascular complications, which differs, or actually is an evolution, of his previous publications. He suggests full reversal with a focused, high-dose unit-based therapy based on anatomical area and not necessarily the amount of filler used, postulating that if we only get a partial reversal, it may lead to further downstream destruction in the ever-frightening delayed phenomenon. He discusses that the diffusion of the enzyme through the arterial vessel wall is really concentration dependent and makes an effort to refute some of the people who state that using a large volume of hyaluronidase may destruct some of the natural hyaluronic acid in the skin. He feels that this is not really the case and that his high-dose therapy is really the best way to help get full reversal of this complication. So I asked Dr. Lambros to tell us about his personal protocol for inadvertent vascular injection. How much hyaluronidase does he use, and has he tried any other ancillary methods? He began by stating that in plastic surgery, just like other aspects of life, suggestions are made as solutions for problems, and oftentimes these get repeated. So things like aspirin, hyperbaric oxygen, nitropase, and others have entered the realm of traditional solutions for HA filler embolism. However, in his opinion, in limited direct experience, nothing has consistently helped except hyaluronidase. Aspirin is easy and innocuous, he says. He states that Dr. DeLorenzi's excellent article describes the evolution of his hyaluronidase use, which is similar to Dr. Lambros' use. Dr. Lambros has only seen a few intravascular injections, and they were small and responded to a single large flooding injection of hyaluronidase. But he does feel that there is sufficient empiric evidence that the DeLorenzi technique works, and that clinical response should be considered as important in the treatment of vascular events and not necessarily a fixed dose or a treatment schedule. Ideally, it would be great to do a double-blinded or split treatment study, but these are difficult to conduct. Dr. Lambros also states that since hyaluronidase is a component of bee stings, he has noticed that injecting undiluted hyaluronidase is painful, so he usually mixes a small amount of local anesthetic with the injection. Next, we moved on to any advice he could give the experienced injector or the unexperienced injector on how to treat a badly bruised patient. And also, as far as management and just overall stress mitigation, if one's concerned about a possible vascular injection, what does he do to proceed through that process? Does he have any special tricks to prevent bruising? So Dr. Lambros says that the biggest anti-bruising revolution in his practice has been the use of blunt cannulas. He states that stiff, swollen, bruised lips are really a thing of the past, as well as bruised cheeks, bruised lids, bruised noses, and foreheads. He feels that his placement with the cannula is no less accurate than with needles, and that the learning curve is mild, and any technique that can be done with a needle can be done with a cannula, except for intradermal application and perhaps injecting onto the periosteum of the temple, he states. Dr. Lambros feels that this change in his practice has been profound. Lastly, I asked him, what is one thing you've changed in your injection practice within recent years that you feel has improved your outcomes and decreased your adverse events, aside from using blunt cannula? And he states that he has really seen an evolution in filler placement in the face worldwide. First it was lips and nasolabial folds, and then as people began paying more attention, uses expanded to the cheeks, lids, temples, nose, and now virtually all parts of the face. In other words, the tool expanded to fix things that maybe we just didn't quite appreciate before. An interesting question that Dr. Lambros posed to me was to contemplate whether the majority of clinicians just did not recognize hollow temples and brows until they really had a tool to fix those areas. He also states that the growing understanding of the face, both personal and professional, is really a key to the development of clinical skill. A good injector will have results which parallel their understanding of the anatomy. While expanding technique, injectors may experience lumps, bumps, and unanticipated outcomes. But Dr. Lambros views this as part of education and essentially harmless if using hyaluronic acid. He actually told me that a driving instructor once told him, if you don't spin out once in a while, you're simply not going fast enough. So Dr. Lambros suggests that a good way to expand an injector's understanding of the face is what he calls a local preview. It basically uses local anesthetic to duplicate the effort of the filler before injecting the filler, and is really analogous to trying on clothes before buying them. This is an analogy that all patients can universally understand. And then, if the patient and doctor like the look of the local preview, then the injection can be done right then and there, and now the area is numb and vasoconstricted. Dr. Lambros' final comment to me was that in his opinion, a poor injector does procedure by ritual in all faces. He thinks that the face should tell the clinician what to do and not the opposite. Knowledge is power. Well, we want to thank Dr. Lambros for his insightful thoughts. Hopefully you'll find this useful, and we'll look forward to seeing you next month.